So when we're positioning you as part of the dental team, the first thing we want to consider is how you're going to be seated. We want to use a dental stool, a doctor stool, that has a piston in it that is tall enough so that it can accommodate your height. Specifically, we want about a 5 to 10 degree angle to the thigh relative to the plane of the floor. So a small angulation here is desirable to be able to hold the back up vertically without the use of muscle. In addition to that, we want to be able to have a seat that has a positive pelvic tilt to it. By moving the pelvis forward into a positive gradation, we're able to move the vertebra perpendicular to the plane of the floor, and now you're able to hold your back in a straight position without the use of muscle. This way you can sustain a position that is ergonomic all day long. But if you had to use muscle, you probably couldn't hold your back up for more than a few minutes. Once we're positioned on the dental stool, the next thing we want to consider is positioning of the patient. Generally, as we all know, we would like the patient's head essentially in our lap. In order to do this in an ergonomic way, we're going to have the patient's feet a little bit higher than their head. And so this is called a modified Trendelenburg position. Notice in the Trendelenburg position that the feet are somewhat higher than is the positioning of the head. And this is necessary for us to be able to get the patient's head into our lap so that we have a very good focal distance from the eyes down to the dentition. And generally that focal distance needs to be somewhere between 17 and 19 inches. Additionally, as we address the patient, we're going to be using, hopefully, a positioning of the neck so that the neck is actually straight. The head is over the shoulders, because the more cantilevered the head is out over the shoulders, the greater the stress on the musculature of the neck as well as the shoulders. The trapezius, the splenius, a lot of different muscles start working overtime, and we end up stressing them, and then they go into tetany, and then we have physical therapy problems. So let's get the head over the shoulders, get in close to the patient, and get the elbows down at the side. And in actuality, that is kind of the pre-flight checklist that we always want to consider when we're getting ready to treat the patient. 3 items. Number 1, a straight back. Number 2, head over the shoulders. Number 3, elbows down at the side. When the elbows come up, we start eliciting movement that is unnatural. It's a class 4 movement. And that class 4 movement is going to really damage the brachial plexus, the deltoids, trapezius, and the musculature of the neck. So we want the elbows down at our side to be able to practice for many, many years without any physical musculoskeletal damage. In order to be able to have patients accept this position, many times it's very important to give them a benefit statement as to why they're going into that particular position for that procedure. And the most fail-safe method of being able to convince them that indeed this is necessary is to let them know that today the doctor is going to be treating a particular area, and in order for the doctor to see what he's doing or she's doing, the patient needs to go into a particular position. After we've positioned the doctor, we've positioned the patient, we need to bring the assistant into the dental team and position the assistant so that they can ergonomically deliver instrumentation to the doctor. In order for this to happen, the assistant has to have some very specific coordinates, both horizontally and vertically. And you'll notice the assistant here has their left hip immediately adjacent to the left shoulder of the patient. And in fact, I call this a full contact sport of dentistry, because this is very, very close, tight quarters. everybody's cramped here, but we're working on a very small area, which is the oral cavity. So we have a horizontal coordinate. The vertical coordinate for our assistant is that we want the eyes of the assistant 6 to 8 inches higher than that of the doctor's. And indeed, his eyes are substantially higher than mine. This positioning allows the assistant to look straight down into the oral cavity, have a channel right into the oral cavity without having to lean over or bend at the trunk at all. And the advantage is they see what you're doing. Once they know what you're doing and when you're doing it, then they're able to deliver the appropriate instrument at the exact right moment, just in time, so to speak. So we're going to have the instrumentation brought up, and as we do, I also want to recognize the positioning of this workstation. The workstation is a deceptively important piece to the puzzle. In this flexible rear delivery setup, in order to deliver ergonomic care, we're going to have the surface of this workstation angled at a 45-degree angle outwardly, so that if we thought of the axis as being straight up and down like this, we're actually angling this workstation outward, giving the assistant and the doctor more work area right over the patient. Additionally, this workstation has been depressed onto the assistant's right thigh, thereby anchoring the assistant into position, because the assistant will feel some instability being so high in the air relative to the doctor. And the assistant's feet then rest on the foot ring. So they're completely anchored, and we're using the abdominal ring or rest actually as a backrest in this situation, so we're able to bring in the assistant next to the patient. The only way this really can happen is if we have a very narrow dental chair. And when I say narrow, one that's probably 24 to 27 inches wide is critical. The wider the dental chair, the farther away the assistant is. The farther away the assistant, the less that she or he can visualize of the oral cavity and the operative field, and thereby becoming less and less of an active participant in the treatment of the patient. Also, I would like to point out that we have plenty of space for the handpiece delivery head, which is here, and the assistant's delivery head, which is here. And now we have completely enough space to deliver the care and to bring all the instrumentation into the field that's needed to effect treatment for the patient. After the patient's been anesthetized and we're ready to begin the procedure, the assistant is in position, and we're going to have the transfer of instrumentation at this point. So the mirror is brought up in position, and then we're going to bring up a handpiece. The assistant's going to hand the handpiece to me by using a reverse grasp of the handpiece initially, and then bringing it to me with the burr facing away from the patient, so there's never the chance of even remote chance of cutting the patient. Now, I then turn the burr into the patient. Additionally, we would have told the patient at this point that they may be feeling a bit of cord laying on their patient drape. We don't say laying on their chest or their neck. We just refer to it as the patient drape. And in this way, the patient is not surprised when they feel any tubing. If you don't care to use the method that has the tubing draped on the patient drape, then the alternative to that is to have the handpiece delivered behind the patient. So in that technique, we have a system in which the assistant picks up the handpiece and delivers the handpiece to the doctor, but the doctor has to move back and drop the cord between the patient and the doctor. Doctor takes the handpiece, and the assistant gets into position, and then the prep is cut. Once the preparation is completed, Now we all have to stop. The doctor releases the handpiece, moves back, then comes back into the field to receive a new instrument and begin treating the patient again. This does take extra time and defeats some of the advantages of the ergonomic delivery. Now the assistant's going to be bringing up the high-speed suction, placing the high-speed suction in their left hand using a dagger grip as opposed to a pen grasp so that they don't fatigue small muscle. Also, you'll notice that the assistant has placed the high-speed suction underneath the left arm to take all the drag off of the wrist. Now they're going to be using deltoid muscle here to actually retract the cheek, really enhancing the endurance of the assistant, and bringing up the three-way syringe for clearing the mirror. So we would begin the procedure and cutting the prep using the handpiece as well as the three-way syringe. And when I'm finished cutting the prep and I now need a hand instrument, the assistant is going to put all of their instrumentation into the right hand, and using their left hand will deliver the new instrument to me, taking the handpiece with the small finger of their left hand, delivering the new instrument to me with the thumb and forefinger of their left hand. And now I've not lost my finger rest, I haven't lost my visual field, and so I'm able to take the instrument and immediately go into the operative field and continue treating the patient. Let's see another instrument transfer. The small finger of the left hand takes the instrument that I no longer want. I let go. They deliver the new instrument to me, and I take that without losing my visual field or losing my finger rest. I go right back to the mouth. I'm treating the patient, and the procedure goes approximately 20% faster with these instrument passes. Then, if necessary, the assistant can bring up the high-speed suction and the three-way syringe again to assist in whatever process needs to be accomplished. It's essential to have a narrow chair because as the doctor approaches the chair to treat the patient, you notice we have to straddle the chair. There's no other way to do this, because if we put our knees underneath the chair, what happens is our elbows necessarily must rise. And this class 4 movement, once again, creates a lot of stress on the brachial plexus, the deltoid muscle, the trapezius, and the musculature of the neck. So we want to avoid that by having the elbows down at our side. And the way we're going to achieve that is the appropriate positioning of you, and then the patient, and then the assistant relative to the patient, to create an ergonomic environment to deliver care that allows you to practice a lifetime.